speaker is the keynote address, Dr. Robert Selby. Dr. Robert Selby is a professor of surgery at the Keck Medical Center of US California School of Medicine in Los Angeles, California. Dr. Selby is the director of the liver transplantation program and chief of the division of hepato-biliary and pancreas surgery. Dr. Selby graduated from the University of Missouri School of Medicine at Columbia, Missouri. Before joining USC, Dr. Selby served as a faculty at the University of Pittsburgh, where he trained in multiple organ transplantation and hepato-biliary-pancreatic surgery. He remained at the University of Pittsburgh, where he was also director of the Multiorgan Transplantation Fellowship. Dr. Selby has trained more than 45 transplant surgeons who currently participate in transplant programs throughout the world. Dr. Selby is a board certified in general surgery and general surgical critical care. His research interests include transfusion-free surgery, surgery for neuroendocrine tumors, primary and metastatic liver tumors, peri-ampullary cancers, pancreatic cancers, bile duct injuries, and cholangiocarcinoma. He has sources of scores of publications in his areas of research interest. So Dr. Selby today is going to address the oncology and transplantation surgery without blood transfusion. And he's going to tell us why and how this can be done. Dr. Selby is all yours.
Thank you. Can you hear me okay?
Yes.
Give a nod if you can hear. Okay.
Yes.
I'm going to try and share my screen here. And it should be right there. Tell me if you all are seeing it.
Yes, right now.
Okay. So, well, this is sort of an acquired interest of mine, and it grew up kind of accidentally. When I was at the University of Pittsburgh, we did lots of transplants back in the late 80s, and we had transplanted 4 adults as that were obligatory transfusion-free patients. And I think 3 of them went well. We wrote up the experience, but it was kind of based on a catch as catch can. It wasn't organized into a program or a broad strategy. And I think probably the hardest part about transfusion-free surgery and patient blood management is building a coalition of interested people and kind of driving it through. And I've seen over the years, a lot of people that are sort of laissez-faire about patient blood management, and very few what I would call true believers. And I think, in some ways it's kind of the ideal platform for somebody who really has an investigative scientific inquiry kind of nature. If there was ever a better control arm than the Jehovah's Witnesses, I don't know what it is, because being obligatory transfusion free, you don't have to persuade them, you don't have to convince them, and for the most part they're not going to cross the line. So they're an ideal background context for patients who are transfusion eligible. So we at USC, we started our program, and I'm going to show you some slides of what our timeline was. Our program, the ultimate goal was really to develop the strategies and refine them in the Jehovah's Witness population, and then be able to practice them universally broadly for all patients, which has happened pretty much for our service being the hepatobiliary and transplant, but abdominal transplant surgery service. We have a dedicated team. We have dedicated anesthesiologists. They all understand it. They all like the witness patients, and it's a challenge for them, and it's one that they've met successfully. But even in our own institution, I wouldn't say that there's a broad interest or agreement in how to go forward with the Jehovah's Witness patients, and that trickles down to patients who are there and they say they want patient blood management, so there's really not any strategy for them. So Let's see.
It's not advancing, Dr. Selby?
I'm just trying to figure out how to advance my slides here. Okay, I guess I figured it out. Okay, I don't have any disclosures. So, I was fortunate enough to work with Dom Starzo for about 10 years, and he's he was a very iconic and iconoclastic figure. He developed liver transplantation, and some of the things that we were allowed to do back then, or maybe not allowed but not prohibited from doing, were bizarre and at the same time they were sort of creating new ground for development. So multi-organ transplantation, cluster organ transplants, transplants for malignancy of every variety, all those were done back at the University of Pittsburgh in over a 10-year period and became kind of a flag in the ground for what is possible surgically. And then the question is it feasible medically and is it sensible? And one of them, I think, was this transfusion-free transplantation for Jehovah's Witnesses. So the way that we get to a smart patient blood management practice is to use what we've learned in the witnesses, hone it, refine it, and then apply it. It doesn't have to be obligatory in the non-witness patients, but it does allow us to offset, even if it's not complete, to offset the losses that we have in the operating room and have less transfusion requirement, which is even beneficial both from a cost standpoint as well as from an outcome standpoint when it comes to morbidities. So this is our program, and like most programs, especially our hospital was rather infantile at University of Southern California. It was kind of an infantile hospital. So, it wasn't built from the bottom up. It was kind of cobbled together. And so we started doing witness patients as not big liver transplants and kidney transplants, but we started doing witness cases. And this was back in 1996. And the whole point of this is to kind of show an outline of how we developed a transfusion-free and then subsequently a patient blood management program. So we had a few cases that we did early on, and then we got a liaison to the Jehovah's Witness community. Many of you probably know Randy Henderson. He's been my friend and colleague for 30 years. And that was quite helpful because it really gave reality testing to the witness population that came in and allowed us to present sort of a unified and persuasive front. For some reason, and I'll tell you what the reason was. Back in those days, we were just starting our liver transplant program, and we didn't have any traction because UCLA was across town and they were doing the most. So we decided we were going to do Jehovah's Witnesses, which I wouldn't recommend as an initial step in developing a program. I think it's much smarter to start with the easy things first. Practice the utility of acute normal bulimic hemodilution and augmentation. See if you can get that to work, and then gradually build your processes within the system, and then do the hard cases. But that's not what we did. So in the early beginnings, after we said, well, we're going to have a Jehovah's Witness program, we started with the development of the processes. That means, like, how do you identify a patient? How do you notify the blood bank and administration that this is a witness patient? How do you notify the phlebotomy people not to draw bloods, and how do you get the acceptances and refusals from the patient? And that's gone on. It's been refined some over the years, but that still is in existence for us. And those are basically our critical pathways. And then, so now we're up to 1998, and probably the smartest, arguably the smartest thing that we did was get anesthesiologists involved in the practice, because, in my view, over all these years, that's still the biggest blockade. And if you think about it, the reason is because anesthesiologists are working on a short-term goal. Their goal is to get the patient out of the operating room safely. So if they're asked to take risks on behalf of the patient, then they're taking risks on behalf of themselves. For the surgeon, you want them out of the operating room, but you don't want them to get a post-op infection. And for the oncologist, you want them out of the operating room. You don't want them to get a post-op infection, and you don't want to get a delayed recurrence of tumors. So, but the first key to developing a blood management practice or a transfusion-free practice is to get the anesthesiologist on board. And then, one of the ways to sort of build a culture of patient blood management is to start tracking your data and then start publishing or presenting at national meetings. And I think probably that's, after getting the anesthesiologist on board, then you've got sort of a partner in the process, and then you start spreading around the presentations and publications, and now you've got something that's got wheels and is starting to have some movement to it. Data tracking, it starts at the very beginning. If you're setting up a program, you've got to be tracking your data early on. And we have what's called a patient blood management timeout. It's like a surgical pause. It's at the end of every case. Now it's more automated so that we pull in data from the electronic medical record. But for years, we had the circulating nurse fill out a form and submit it paper form, and then we enter the data in for our patients so that we at least had real-time data, even if it was on paper. And having that is indispensable if you're approaching insurance companies, if you're trying to get traction from the hospital for any resources and so forth. And then at this point, we're trying to get physicians, stakeholders into this process. And I would say that it's a global idea and it's a global strategy, but it's very, very local when it comes to being able to implement something that's going to work in your own hospital. You really have to build consensus, and then you have to make people as well as you can, make them understand how you make it safe and how their risk is less and how the patient's risk is less if you use transfusion-free techniques. So now we've got some major JW cohorts from since 1997 up until now. And then we started putting in some QA processes here. And that was basically, we were trying to make it so that the patient safety was secure, that nobody was trying to dissuade them from being a witness and refusing blood products, and that people understand that they weren't going to get phlebotomies and that the patients could refuse blood draws. And so all the things where you've got friction between the environment that is there in your hospital and the beliefs of the patient, and sort of deter the hospital environment away from the idea that, it's another witness, and oh my gosh, we're going to have to bend and possibly break to support their practice. And the whole idea is that we're trying to form a safety net that works so that nobody has to bend or break. So then in the last few years, what I tried to do, there's a couple of things. One, I wanted to set up a credentialing module for a TFS PBM program, but really there needs to be a credentialing module for transfusion practices in general. We've got to do them for harassment. We've got to do them for equity and diversity. We've got so many health stream modules that we now have to do, but yet it seems like the whole idea of transfusion practices has gone fallow, and there's really no way to grow people's practical understanding of how to do minimize transfusion and conserve blood. Okay, so then the last thing I think is to build hospital-based committees, and through those committees you sort of modify the appearance of the program, and you develop influence in the blood banking, tissue, and transfusion committees, possibly in the pharmacy and therapeutics committees, possibly looking at point-of-care testing in the operating room for thromboelastography and so forth. So then in the end, this is what I see as a blueprint for the program. And these are all the things that I just told you. You first start off, you develop your data tracking very early on. You don't do the hard patients early. You get critical pathways so that you can identify where the rubs are between the Jehovah's Witness population in this particular case and the hospital typical administrative practices. Get anesthesiologists, and most importantly is to start publishing early on or presenting, even if it's just local stuff. We have 47 peer-reviewed articles just from our own division. And, we're in the process of doing up the global experience that goes all the way up through the end of this year it'll be close to 3,000 patients. So, and then these things are sort of added, I guess, ballast to the whole idea of a program. If you've got a QAPI part, especially a patient blood management policy, you can get people to buy into credentialing module. These are things that really give it traction and make it really part of an integrated program in the system. So I did want to say a little bit about A&H because of all things, A&H is the godsend for the surgeon and for the anesthesiologist. And the nice thing about it is it's so simple to do. It doesn't require a consent. It requires a willingness of the anesthesiologist to do it. And the physiology of it is quite amazing. And it's just a representation of the fact that, anemia is well tolerated by the vast majority of patients. This is the physiology that happens if you read it from right to left. Once you take off blood and replace with colloid or crystalloid, then the heart rate goes up as a compensating mechanism. And of course, the SVRI is going to fall, and then the stroke volume index goes up, and the cardiac index goes up. So it's a real simple measurement of a physiology principle in action. And then you keep your oxygen delivery and your oxygen consumption are supported until really a hemoglobin of around 5. And I'll skip that slide. So just so that you don't have to have the whole hospital decide the practices of patient blood management. You as an individual surgeon or anesthesiologist can practice it in the operating room. And that's where I find it of most benefit. So on every patient that we have that gets a liver resection or a Whipple or anything that looks like it's going to be more than a 300 or 400 cc blood loss, we do A&H on them, all of them. We don't do cell saver that often because it so often happens that you set it up, you pull off some blood, maybe 100, 150 cc's, and then they throw it away. So we don't usually set up for patient blood management. We usually don't set up a cell saver, but we always do A&H now, always. And we don't have that 1 unit blood transfusion. It's really gone away for our particular service. So I think that the A&H is a strategy that transcends the witness population and should be very central to patient blood management. I'm sorry if I'm running behind a little bit here. So here in our population, we've done over 2,500 patients, and I'm not talking about endoscopies or hernias or tonsils. I'm talking about major procedures since 1997, and this is my take on it after all this time. If it's an elective operation, you better have a normal hemoglobin and a witness. You absolutely better. And if you're expecting bigger blood losses, you can get a hypernormal hemoglobin, even if you have to, obviously there's a black box warning for hypernormal, but if you're going to need it, you're going to need it. So you can tell the patient, get the consent, and even anticoagulate the patient pre-op. This second one is the most important thing for surgeons. I don't know how many surgeons there are in the audience, but if you're going to do obligatory, transfusion-free practice, you better know what your expected blood loss is going to be, and you work backwards. In other words, you know the procedure, you know the circumstances about the patient. Is there portal hypertension? Is there a lot of previous surgery? Is there obesity? What's going to augment your need for blood as a safety net? And then once you anticipate this, you work backwards and you pull off the amount of A&H that you're going to need to support that blood loss. In the operating room, you cannot have hypovolemia if you're going to promote anemia. You've got to have monitoring, and that's kind of disappeared in this day and age with CLABSI and CAUTI and all that. This is counterintuitive for the management, for patient blood management, I think, and central monitoring. Everybody knows that there's redundancy in the hemoglobin, and there is a lot of redundancy in the clotting factors. So we're lucky in this regard because it allows us to take off whole blood and dilute down. I'll show a slide about that. And then post-op, we have to be more vigilant about phlebotomy. Tell me how I'm doing for time if you... So this is our patient blood management timeout. I just wanted to show this because it basically is a register of the patient's kind of procedure. Is it an emergency? What's the nature of the procedure? Starting hemoglobin, typing across yes or no, ANH utilized and how much you took off, how much estimated blood EBL was, and cell saver and so forth. So these products are these manipulations are very valuable if you're gonna start data tracking your patients. I'm gonna skip that. So here's, whenever I think of the blood system, I think, okay, we're gonna have to, we're basically manipulating the blood system, and each element may have to be manipulated in the course of an operation. It certainly has to be anticipated. In other words, are the coagulation factors normal? Cellular elements normal? Do you have fibrinolysis? And if you think you might, you need point of care testing with a thromboelastography so that you can give the you know, the factors that can prevent the fibrinolysis. Intravascular pressures are very important, and sometimes I'll even pressure transduce the portal vein, or even put a pressure transducer in the liver proper, just to make sure I don't have high or low pressures. Vascularized adhesions can be a nightmare in a transplant patient. So all those things are gonna pre-exist, and you can anticipate when it comes to the ANH. And so this is the most important slide. And we just published an article on tertiary level HPB surgery in witness population. I think we had 70 or 80 patients. It was in Annals of Surgery a couple of years ago. And this, we did our calculations. This is for hemoglobin reduction with each aliquot of ANH that we took off. And this is for a 70-kilogram male. And you've got parallel structures for females or higher or lower weight, but it's still, it mirrors this. And so this is the ANH removal volume on the x-axis down below. You've got 7 units that you can take off as you're hemodiluting in real time. So you're dropping your hemoglobin from 14, 15 down to 8, just below 8. And so you can get off 7 units of ANH and park it at the, in the cooler, or in the, whatever vehicle you've got for holding it, a rocker or something. You can park it there and use it as you need it. There is nothing more assuring, even on a transplant, than to have the anesthesiologist and the surgeon look over and see that they've got blood in the room. And that eliminates the fight with the blood bank to get the blood up there, which is often a big fight. And maybe it's 20 minutes, maybe you're lucky and it's 2. It's always on the way, but it's never in the room. So this is the most reassuring thing that you can have as a surgeon or as a program manager or an anesthesiologist, is to have as much ANH as you think you're going to need to offset the blood losses. You don't have to do this calculation if you're just doing patient blood management. You can say, well, it's safe enough to take off a couple of units. We'll do that. And then if we lose more than we need after that, after we've given the ANH back, then we're good. So I wanted to, and abiding by this particular principle has saved ourselves so much grief. And I'll show you in just a minute when we took off 7 units of ANH on a patient for 3-liter blood loss. So over the years, we've checked on the amount of blood loss that's a likely expectation for big procedures, because if we're going to use ANH in the most sophisticated way, it would be on the hardest cases. And if you can use it and effectively on the hardest cases in a witness, then we're home free. The requirements for blood banking and blood administration would go way, way down. Hospital costs would go down. So this is what expectations are for these particular procedures. For HPB, lobectomy, triseg, Whipple, distal, retroperitoneal sarcoma, for foregut, esophagus and stomach gastric resections, big, AP resections and pelvic floor for the colorectal, cabbage, mitral valve, aortic valve, pneumonectomy and lobectomy. And these are all, 500 plus cc's of blood loss. And these are, for the most part, I would say 95% of these in our data collection are elective operations. So we've got an opportunity to manipulate the patients ahead of time. AAA, a lot of these AAAs were actually ruptured, and so those were included in the data. For neurosurgery, these 2 knee replacements, redo knee replacements were also, knee and hip replacements were also in here. And a lot of times the blood loss in these is post-op in the drains, radical hysterectomy, and here's some nephrectomies, cystectomies, prostate, and so forth. Let's skip that slide. So this is our data from 97 to 2021. I haven't re-crunched it yet for the last 3 years, but that's what our global publication is going to be about. So we've done 34 kidney transplants up until that date, 3 donor nephrectomies, 4 pediatric liver transplants, 3 live donor. These are cadaveric, these are live donor. 41 liver transplants in adults, live donor, 6 cadaveric. That's where the highest mortality was. 37 Whipples, 22 Whipples, 14 distal pancreatectomies, and 62 major liver resections. So these were almost all of these, except for 1 liver resection and 3 cadaveric adult liver transplants, were all elective cases. So they were all prepped. The 3 patients that we lost on the cadaveric were all highly decompensated. We shouldn't have done them. And the one that we lost here was a ruptured liver tumor. Everything else was elective and was successful. I'm just going to say, how am I doing for time?
I would say 2 to 3 minutes.
I'm sorry?
2 to 3 minutes would be good.
Okay. I'll skip this. Basically, this just says that if you use a cell salvage, this is from a study at Mass General, if you use cell salvage and you have an R0 resection, you're not spilling circulating tumor cells in the blood, and you can use it freely. So we now, on all resections where we're expecting a clean resection with a clear margin, we're using cell salvage. I'm going to skip this live donor liver transplant because I wanted to get to the last slides in. Okay, so this is our experience with the first 5 witnesses that we had. And starting hematocrit here, not hemoglobin, but hematocrit, the number of units we took off, and how much the blood loss was for this particular patient that's starting hematocrit of 49.5, and then how much we gave back in the cell saver and the final hematocrit. So this guy has spleen and liver were stuck together. He had a 2-stage operation, got a liver transplant, then later on we came back and took a remnant piece of the liver that was stuck to the spleen off. He lost 2,900 cc's of blood in the first operation. He had, it's almost 2,800 cc's of cell of ANH, and he ended up with a final hematocrit of 44, almost 45. So this is consistent throughout all these. This is the most we ever took off, and he didn't turn a hair. It's a slow process. You don't get it all off in the very beginning, and there's no urgency about taking it off, especially as you march through the first hour of the operation. But by the end of an hour, you've got 7 units of ANH, and this guy was a save. This is a comparison between transfusion-free and transfusion-eligible patients, pre-op, hematocrit pre-op, post-op, median units transfused 0 and 4.5. And I'll skip that. Okay, so for the rest of these I just showed you the hepatobiliary, but these are the other patients. This is a cardiothoracic surgery, heart transplants, cabbages, thoracic aneurysm, valve replacement, sternotomy, pneumonectomy and lobectomy, diaphragm hernia, lung transplant. Oh, that's wrong. That's a mistake. I'm sorry. The total knees and redo total knees, shoulders, and hips, and then redo total knees, shoulders, and hips, implant removals, open reduction, internal fixation, laminectomy. These are often bloody. Scapulectomy, sacrectomy are bloody. For GYN, so you get the picture. I mean, it's the toughest surgeries. For every service line has their bad actors, and this is basically a testimony to the fact that if it has to be done transfusion free, it can be done using a strategy. And this, again, these are not, very few of these were emergency surgeries. The foregut and colorectal, the same things. This is vascular, AAA repair, open amputations, vena cava excision. Some of these wouldn't require blood normally, but a lot of them do, a lot of them. So we've included in all this is the top 20 procedures that you would see in an institution that's a tertiary, quaternary level institution where they would lose a lot of blood. And that's it for that. This is an old slide. I love this slide because it mirrors my experience. It was just a slide at one of the hematology meetings, but it was what's the tolerance of an anemia? So here's 6 to 7, 5 to 6, 4 to 5, 3 to 4. And you can see that it really doesn't fall way off until you hit about a hemoglobin of 3. and this is my experience. I had two patients that got live donor liver transplants, and one patient I took to the operating room with a hemoglobin of 2.5, and she had a cryptococcal peritonitis, and she had the debridement, and she survived, went home. I'm going to skip the phlebotomy thing, although it's a pain for me. So I think that the great part about our experience is that we've basically shown that elective surgical cases of almost any kind can be undertaken, certainly with patient blood management. That's a no-brainer. But even with a witness, if you develop the strategy and you've got people that are willing to understand and participate in the strategy. However, our biggest problem of all is that we have very little penetration of the core practices, A&H, cell salvage, blood augmentation, and those are so simple, except for a pocket full of true believers. And it's been that way, at least from what I see. And I've practiced it at a lot of different hospitals in Southern California. And it's the same story everywhere. Unless you're in there pitching on every patient and you're a major leader in the operating room in those institutions, you're not going to get traction with transfusion-free practice. Okay, well, I think I think I'll stop there.